Good day. We're still busy with the obstetric hemorrhage. I'm still Anna Nolte, and today we are going to do lesson 3, which is the active management of the third stage of labor and postpartum hemorrhage. Now, the reason why we include the active management of the third stage of labor here amongst the obstetric emergencies is that evidence has shown that by managing the third stage of labor actively, one can decrease the possibility of postpartum hemorrhage by a very large percentage. And this is specifically very important for patients who are delivering in the public sector, where the patients are going home shortly within 6 or more hours after the birth of the baby. So we will briefly talk about that and then do postpartum hemorrhage. Now, what happens during the third stage of labor is mostly the separation of the placenta and the birth of the placenta. So what happens now is the uterus is empty, the uterus is getting much smaller, and that causes the retraction of the uterine muscles. Retraction, remember, is different from contraction in the sense that the muscles retract, they get shorter and they stay shorter. So that makes that the uterus now becomes smaller, and that causes the placenta to be compressed. And the placenta is, the uterus is, the walls of the uterus is stretchable and compressible, but the placenta is not. So that makes that the placenta then gets loose, and we get obviously bleeding. This placenta has been separated and the placenta has been born. We will come to that just now. Now, the control of bleeding during the third stage of the labor is the most important to us. We have talked several times when we talked about the uteroplacental blood flow and the formation of the placenta. We've talked about these villi, finger-like protrusions that grows into the uterine wall and grows through these maternal arteries. So when the placenta has now been born, obviously these maternal arteries are sitting open. There's just nothing here, and that can cause a massive bleeding, because we also know that there's quite an increase in blood flow to the uterus during pregnancy and labor. So what happens now is, because of the retraction of these muscles, as we've said, here you can see in this, the villi, the uterine villi, the placenta here, and the placenta is getting loose, and these blood vessels, maternal blood vessels, are literally sitting open. So here, these white strands that you can see here are representatives of the uterine muscles. So the moment that the uterus starts contracting and retracting, we literally see that these muscles are becoming shorter and retracting, and that literally binds these blood vessels off, so that we don't get any bleeding here in the placental area from the maternal side. And this to us is extremely important in the control of bleeding during the third stage of labor. Now, if we look at the normal homeostasis of during the third stage of labor, we say that there is a normal loss of blood because of from where the placenta goes loose till the retraction has constricted all the blood vessels, and we say it's normal for the mother to lose up to from 5 to 800 milliliters of blood. And as we've said in the previous lesson 2 with the antepartum hemorrhage, there's an increase of 35% blood during, or 45% of blood volume during pregnancy. So the mother can easily lose this blood without having been shocked or without her system being affected by it. When there's a blood loss of more than 1,000 milliliters during the postpartum period, we call it a postpartum hemorrhage. We've talked about the retraction of the uterine muscles and how it constricts the maternal blood vessels. And now we also get a certain amount of contraction of the uterus, and you can see that the walls of the uterus are becoming thicker and stay thick because of the retraction, but we also get to a certain extent contraction as the uterus contracts after the birth of the baby. And we can see here how the contraction of the uterus causes the placenta to go loose, also causes a retroplacental clot here that makes that parts of the placenta goes loose, the placenta comes out. And very important also here, as the uterus contracts, the walls of the uterus, this literally the hole in the uterus, if I can call it like that, contracts so that the walls, the sides of the uterus are coming to each other. And this also, the same time that all this happens, there's also to a large extent the activation of the coagulation and the fibrinolytic systems. Now, this does not play a big role in the control of the bleeding and specifically in postpartum hemorrhages, but this is also very important to control bleeding. And then also we know that oxytocin causes the uterus to contract. If the mother do breastfeed and she starts breastfeeding, oxytocin will also be secreted, which causes the uterus to contract further. And that also helps with a normal homeostasis during a normal third stage of labor. Now, the very, very big important thing during the third stage of labor is to observe for postpartum hemorrhage, to make sure, first of all, that the placenta has been born, that after the placenta has been born, that the uterus contracts and that the uterus stays contracted. There are two ways that the placenta can be born. The one is passively and the other one is actively. And the names exactly tells you what it means. Passive management of the third stage of labor means we absolutely do nothing and the placenta has been born normally or naturally. And the word naturally tells you that people who are very pro-natural birth would obviously be very pro-passive management of the third stage of labor. But as I've said, evidence has shown that active management of labor decreases the possibility of postpartum hemorrhage. And postpartum hemorrhage, as you have seen in the previous slides, is the third biggest cause of maternal deaths in South Africa. So we really want to prevent postpartum hemorrhage. So what we do is with the passive management, as I'm saying, we do nothing. We wait for signs of the placenta going loose, and that will be a fresh gush of blood coming out, and this is as the placenta is going loose and that retroplacental clot is coming out, as I've shown you just now. The cord lengthens because the placenta is now coming down into the uterus. The uterus starts contracting and the placenta might appear in the vagina. And we don't give any oxytocin before the birth of the placenta. In some cases, oxytocin can be given after the birth of the placenta. In very pro-natural people, they prefer to not have any medication. Then the active management of the third stage of labor, as I've said, the name tells you we are active. We almost make the placenta to be born, if I can call it like this. So this now, after the second stage of labor, if there are no twins, if there's not another second baby in the uterus, we've made sure that there was not an undiagnosed twin, we usually give 10 units of oxytocin. The reason for that is we literally make the uterus to contract, because the oxytocin makes the uterus to contract. So we wait for a uterine contraction. We can stand with our hand on the uterus and feel that the uterus is becoming hard, so the uterus is contracting. And when the uterus contracts, we do what we call a Brandt-Andrews removal of the placenta, or a Brandt-Andrews management of the third stage of labor, or as we've said, active management of the third stage of labor. What we do is, with the one hand, we support the uterus on the abdomen, and the reason why we're doing this is that we make 100% sure that we're not pulling the uterus out and causing an inversion of the uterus, meaning we literally make that the uterus is coming out. So with the one hand we support the uterus, and with the other hand we cause very subtle cord tension. Put a little bit of steady tension on the cord, and we literally slowly pull the placenta out. Now, also again, why it is not really pulling on the umbilical cord, for two reasons. You might break the umbilical cord in the first place, or again, and if you pull too hard, you might pull the uterus out. So that's why it's really a steady tension, but I almost want to say a tender tension on the umbilical cord. Then after the placenta has now been born, we make sure that the uterus contracts, and we watch the patient in the sense that we are checking the uterus regularly to see that it's contracting and it stays contracted. And we also teach the patient how that they can control and feel for their own uteruses to contract and to make sure that the uterus is contracted. Then we examine the perineum to make sure that there are no episiotomy or tears, or obviously if we have done an episiotomy, whether the episiotomy has torn further or not. We determine the blood loss. We examine the placenta to make sure it's complete. We do the maternal observations. We empty the bladder, which is very important. The bladder should have actually been emptied before the patient went into the second stage of labor, because very often a full bladder is the biggest reason for postpartum hemorrhage. And then we can put the baby to the breast, which is good for breastfeeding as well as for contracting the uterus. Okay, now when we come to postpartum hemorrhage and we look at the causes of postpartum hemorrhage, the biggest cause of postpartum hemorrhage is atonic uterus. The uterus does not contract. And as you will remember on those slides that I've shown you in the third stage of labor, how the muscles constrict the blood vessels and makes that the blood vessels are being closed off. In an atonic uterus where the uterus does not contract, that obviously can't happen. Those blood vessels are open, and a postpartum hemorrhage can be a huge hemorrhage. Like you see in this diagram, it's literally looks like a hose pipe that's been opened and the patient bleeds a lot. So this is really, really a serious emergency. Now also you will see that all these or many of these signs causes are being associated with the atonic uterus. First of all, secondly is incomplete placental separation. The part of the placenta is going loose, but the rest of the placenta is not going loose. So where the placenta has gone loose, those blood vessels are sitting open, but the placenta being still implanted makes that the uterus can't contract. So those blood vessels that sits open will bleed a lot. Then I'm always saying where there's something wrong with the muscles, the contractions during the first and second stage of labor, it causes problems during the third and postpartum period as well. Like, for example, precipient labor is when the labor is from first stage to third stage of labor is less than 3 hours. The uterus sometimes does not contract properly and we get a bleeding. The same is also true for prolonged labor. I unfortunately don't have prolonged labor here, but prolonged labor is also a big possible cause of an atonic uterus. The uterus, the muscles of the uterus might be so tired of contracting that the uterus stay atonic during the third stage and postpartum period. A very big uterus, the uterus was so stretched out that the muscles can't properly contract again, and that's in the case of a hydramnios in a multiple pregnancy. And in the case of a multiple pregnancy, we also have a very big uterus, a placenta usually, with a big placental wound, and together with this makes the possibility of postpartum hemorrhage in the case of a multiple pregnancy just so big. We have talked in the previous lesson about placenta previa and abruptio and postpartum hemorrhage. And then induction and augmentation, very often we get a kind of a reaction of syntocinon, a reactive kind of reaction, in the sense that if you stop, the patient had been induced or augmented with oxytocin, and over a period of time, and now, say for example, the IV infusion, the vacuoliter is empty, and now you stop the IV infusion. We often get a reactive kind of bleeding because I think the uterus is so used to the oxytocin making it contracting that when you stop it suddenly, the uterus relaxes and doesn't properly contract. So when you do stop at the end of labor, the oxytocin infusion, do it over a period, do it gradually. Then episiotomies, any tears, any injuries to the episiotomy, the perineum and the cervix might also cause bleeding. General anesthesia might sometimes cause the uterus not to contract very well. A full bladder is one of the biggest, as I've said previously, causes of a postpartum hemorrhage. You can see where the bladder sits here. So when the bladder is full, it pushes the uterus up and it makes that the uterus can't contract properly. And that is very often one, if you empty the bladder, you stop the postpartum hemorrhage, because that is one of, as I'm saying, the biggest reasons for postpartum hemorrhage. Fibroids in the uterus makes that the uterus can't contract properly. And then anemia. Anemia does not cause postpartum hemorrhage, but if a patient is anemic, she can't handle, her body can't handle the shock of and the loss of blood easily. So if a patient with a HB of 15 milligrams per 100 milliliters of blood bleeds, she's not so much in shock as a patient with a HB of 9 or 10 or even 8. So it is very, very important to make 100% sure that the patient is not anemic when she goes into labor. That is why it's so important to regularly determine HB levels during pregnancy. How can one prevent postpartum hemorrhage? One can't always prevent it. One can try and prevent the effects of the postpartum hemorrhage on the woman. For example, we can make sure that she's not anemic, as we've said just now. So routine iron supplementation in pregnancy and regular determinations of the HB levels, we make sure that the patient is not anemic. So she's in an optimum kind of condition to handle the postpartum hemorrhage. Then to prevent prolonged labor, as I've said, in prolonged labor, the uterus gets so tired that eventually it can't properly contracts, and obviously by using the partograph or gram, we can make sure that the patient is not in prolonged labor. Active management of the third stage of labor, I have said that already makes that the decreases the incidence of postpartum hemorrhage, and there's lots of evidence for that. And then if we identify a woman at risk for an atonic uterus, and that's now all that list of patients with a very huge big uterus, etc., it's always a good idea to, when the patient is in the first stage of labor, to already put up an IV infusion to make sure that we have an open line. And then we can also, after the patient has been delivered, give an additional oxytocin and IV to just make 100% sure that the uterus stays contracted. And that's now after the active management of the third stage. So though the placenta has been out, then we give additional oxytocin, and we make it run over at 120 to 240 milliliters per hour. Then obviously very, very close observation of the vital signs, the uterine contraction and bleeding in the fourth stage of labor, as well as in the postpartum period. And remember, the vital signs are not always good signs or good indicators of postpartum hemorrhage, like we've said in the antepartum hemorrhage. Patient has lost quite a lot of blood before we see it in the vital signs. So we have to make sure that the uterus stays contracted, and we have to see and look for the amount of blood that the patient loses during the third, fourth, and postpartum periods. And then routine postpartum and post-cesarean section monitoring for bleeding is extremely important. Now, just a reminder, what we've said in the placenta previa and abruptio previous lessons, and I've said it just now again, is that often because of the physiological changes during pregnancy, that in the increase in blood volume, that we don't always easily recognize obstetric hemorrhage. Now, this is almost exactly the same as in all cases of haemorrhage, like we've done in the antepartum hemorrhage. The principles is IV, 2 large bore cannulas or 2 lines with Ringer's lactate, sent off blood samples for cross-matching, give IV fluids and blood if available, and it depends also on, again, the condition and how much blood the patient has lost. To catheterize the patient, now in this case, in the postpartum period, we catheterize the patient for 2 reasons. As I've said, the one is to make sure that the full bladder is not the reason why the patient is bleeding, and also to monitor the intake and the output of the patient very carefully. And then we have said that now several times, if the patient loses a lot of blood, there's always the potential of coagulation disorders because she's losing all her coagulation material, if I can put it like that. And then continuous and continual and very accurate monitoring of the vital signs. Now, the questions that we ask ourselves when we are dealing with postpartum hemorrhage are these. Is the uterus contracted? Because we've said that that's one of the big reasons why the patient is bleeding, is that the uterus is not contracted. If not, we have to get the uterus to contract. But before we can do that, we need to make sure that the uterus is empty, because if the uterus is not empty, it will not contract. So first of all, make sure the uterus is empty, the placenta is out. If the placenta is not out, we need to get the uterus empty, because it will never contract while the placenta is still in. We will come to that just now as well. After that, now, is the uterus contracted? If the uterus is contracted, we're happy the patient's not bleeding. If the uterus is not contracted, we have to get the uterus contracted. If the uterus is contracted and the patient is still bleeding, she might not bleed from the uterus and the placental wound. She might bleed from some trauma. As I've said, some trauma to the cervix or the perineum. We have to find the place where she's bleeding from. Very important, is the uterus there? I've told you that there's a possibility that you could have pulled the uterus out when you've done your active management of labor, so we might have a uterine inversion, and if there is a uterine inversion, we will come to that at the next lesson. We have to correct that immediately, because that is a big problem for bleeding as well as shock for the mother. Now, okay, we've said, first of all, we must make sure that the placenta is out. If the placenta is not out, we need to get the placenta out. We need to get the placenta out so that the uterus can contract. So first of all, we insert the urinary catheter. Again, we do it for 2 purposes: to control the input and the output, but also to make sure that the uterus can't contract properly if the bladder is full. So to make sure that the uterus contracts. Then we start with the infusion with oxytocin, 20 units, because again, if we can get the uterus to contract properly, the placenta could go loose. So we put an additional 20 units of oxytocin in a Ringer's lactate drip. Now, the units that we can give during the postpartum period, we usually say that we should definitely not go higher than 5 units during the first stage of labor. But one can easily go up to at least 40 units during the postpartum period, as long as we remember that oxytocin also causes water retention and water intoxicity. So we just need to remember that. But we can put up start an infusion with 20 units, and hopefully the empty bladder and the oxytocin will make sure that the uterus contracts and that the placenta has been born. So now we observe the woman constantly for bleeding, of vaginal bleeding. Now, what can happen with the placenta still in is, if the whole of the placenta is still in and nothing has gone loose, we often get that the patient has a placenta inside but without any vaginal bleeding. And then we're happy. Then we have time. The patient can, we will see just now, the patient can be taken to the theatre and the placenta can be removed. But if a part of the placenta has gone loose, as we've said previously, then is where our big danger for vaginal bleeding is coming from. So we have to remove the placenta then as quickly as possible. And we do it actively. There's now already oxytocin, and we use support the uterus with our one hand, gentle traction on the cord with the other hand, and we hope that we get the placenta out in this way. Now, if there's now excessive bleeding while we are trying to remove the placenta, we can put up a second intravenous line for fluid resuscitation. And then, unfortunately, the only way that we can do is to remove the placenta. If the cervix is still open and if the placenta has now partially loose, and that causing the bleeding. Because as long as the placenta is in the uterus, it might be a problem. Now, if we've said that if the placenta cannot be delivered or has not been delivered after 1 hour of oxytocin and infusion, and the patient is not bleeding, we can arrange for a manual removal under general anesthesia. But if the patient is bleeding, the placenta must be removed manually as quickly as possible. And then after that, we take blood for HbA and cross-match to replace the blood that the patient has lost. Now, unfortunately, a manual removal of the placenta is not something that we can practice. So one has to know the theory of removing a placenta manually. Now, this is usually a very sore, painful procedure and shouldn't be done except if it's an emergency. But if an emergency, there's nothing else that one can do. And what we usually do is the umbilical cord directs you to the placenta. So with a little bit of traction on the cord, you follow the cord with your other hand till you reach the placenta, and then you gradually just peel the placenta loose. As I'm saying, this is usually a very painful procedure for the woman, so one needs to be quite careful with this. Then what do we do if the uterus is still atonic? The uterus is still not contracting and the placenta is out now. And this is usually, as I have said previously, when the patient is really bleeding a lot because all these blood vessels are sitting open now. So we need to this is really an emergency. We need to call for help and we need to rub the uterus to expel clots and try to induce the contraction of the uterus. Now, very often, I think for those of you who have experience with this, very often you rub the uterus, you feel that the uterus contracts, and the next moment you can feel under your hand how it relaxes again. So what we need to do, our main aim here is to stimulate the uterus to contract. So first of all, patient is losing a lot of blood rapidly, so we need to replace it with Ringer's lactate, and we put up another oxytocin 20 units drip if we haven't had it on already, so we put one up. We make 100% sure that the patient bladder is empty. As I've said, we're doing this for two purposes: to get the bladder empty and also to control the input and the output. And then we can continuously massage the uterus and manually remove formed clots, because the moment that they form clots, it also, as long as there's something in the uterus that makes that the uterus can't contract properly, the patient will bleed. So we need to get clots out of the uterus. And then if nothing works, and we will come to more medication, if more medication and all these things that you have done does not work to make the uterus to contract, one needs to apply bimanual pressure of the uterus. What one needs to do, and there are some other maneuvers and things that one can do as well. The principle here is, like in any bleeding, is to put manual pressure on where the blood is coming from, where the source of the bleeding. And that's what we're doing in applying bimanual pressure. And again, bimanual pressure is not something that you can control, that you can practice. It's something, again, that you need to know the principles of, so that when it's really necessary, you have to do it. So what you do is you put your one fist in this anterior fornix of the cervix and your other hand on the abdomen and literally presses the uterus between your upper hand and your lower hand, because to control the bleeding. And obviously you will have to keep on with the pressure till the patient can go to the theatre for to control the bleeding. Now, still, if other measures that one can do, the patient is still bleeding in spite of the fact that the placenta is out, we can continue with the oxytocin infusion, and as I've said, we can even go up to 40 units of oxytocin, and one can give one repeat dose of ergometrine or symptometrine. Now, ergometrine is not been a drug that you find very often in many of labor wards anymore. So symptometrine would be the one recommended one. Now, symptometrine causes a tonic contraction of the uterus. It's better than syntocinon because syntocinon causes a gradual contraction of the uterus. So one can give one dosage of symptometrine and we can repeat it once again. We can also give misoprostol, 400 milligrams sublingually or rectally. One can insert a condom catheter, as you can see here. One inserts an open condom and we connect it with a Foley's catheter at its base, and we fill it up with water, 400 to 500 milliliters of saline, and we clamp it. And this works to a certain extent similar to the bimanual pressure, in the sense that this put pressure on the wound, placental wound of the uterus, hopefully, and that causes pressure on the wound and hopefully prevent bleeding. One can also pack the vagina with swabs to prevent the expulsion of this catheter. So one puts swabs here in the vagina to keep this catheter in its place. And one should now, either the patient should go to the theatre immediately, or the bleeding should stop for at least 8 to 12 hours before one can remove this, because if the bleeding hasn't really stopped, the moment that you remove this, the patient will start bleeding again. And then further, if the bleeding is not stopping, obviously the patient needs to go to the theatre for a manual exploration of the uterus. What is going on? Has the uterus been ruptured? Are there wounds, trauma in the uterus, or are there trauma of some of the blood vessels that can be bound off, etc. Now, just coming back to the different drugs that we can treat for used to treat uterine atony is the oxytocin that we've talked about. We can use intramuscularly 10 units. We can give intravenously 2.5 units slowly, directly, and then we can put up 20 to 40 units in an IV infusion of 1 liter. And as I've said, one should be just very, very careful that for the water intoxication, that's a possible effect of oxytocin. So one should avoid to use more than 3 liters of fluid containing oxytocin. And that's why it's also very important to have 2 lines, IV lines, so that you have 1 line where you can give the fluid quickly and that you have 1 line where you can give oxytocin through. Then symptometrine, as I've said, we can use a symptometrine or ergometrine. Ergometrine has not been used in many of the labor wards, so we usually use symptometrine. Symptometrine is a combination of ergometrine and oxytocin, and as I've said, that causes a tonic contraction of the uterus. That makes the uterus to quickly contract, and one can repeat that twice. We can do it twice. One should be very carefully, we have talked about this when we on the slides and the lessons that you've done about hypertension and preeclampsia, because it causes a tonic contraction. All the blood that is in the uterus is immediately being forced literally into the circulation, and that might increase the problem here. And then, as we've said, misoprostol, one can do 400 to 600 micrograms orally or rectally. And then your biggest problem here is pyrexia. Okay, and then when you've done every possible thing to control bleeding and to get the uterus to contract and the patient is still bleeding, one should make sure that the bleeding is not coming from some or other trauma in the genital tract, like in the cervix or in the perineum or etc. So one should examine the perineum very carefully for perineal tears and episiotomy that has torn further, and therefore it's also very important to examine the vagina digitally to really feel that there's not other tears in the vagina that is bleeding a lot. And then obviously also the cervix, cervical tears are bleeding, can bleed a lot. So one must make sure that the cervix is also not bleeding. And this is not so easy to really examine the cervix. One needs to do that with proper speculums, and the ideal is to also do it in theatre. It depends on how uh, actively the patient bleeds and if there's really time to take the patient to the theatre. Then very important are your observations post-bleeding. Obviously, the vital signs of the patient to see that they are recovering, that they go back to normal, the blood pressure and the pulse rate, and also the vaginal bleeding, to keep on doing pad checks. Specifically in an atonic uterus, it can relax again. And here it's very important to regularly rub up the uterus, and here it's also very important to teach the mother to rub up her own um, uterus. And then very important, the urinary output together with the intake to make sure that we are replacing all the fluids that the patient has lost, and temperature to make sure that there's no infection, because with all the manipulation, etc., intrauterine maneuvers, etc., infection can be quite an easy complication of a postpartum bleeding. Now, just a few words about the excessive bleeding after cesarean delivery, because that still can happen as well. Now, usually after cesarean delivery, we know that the placenta has been out. So the placenta is not the problem. So some or other reason, the uterus is not contracting properly. So again, the principles are exactly the same. One needs to assess the general condition, the vital signs of the patient, the heart rate, the respiratory rate, and the blood pressure, and then the 2 IV infusions. And one can, usually the patient will have an IV infusion on, in which one of them we can put more oxytocin, and the other one we need to run as fast as possible for fluid replacement. Usually the patients have urinary catheters in, but if they don't, to insert one to make 100% sure that the bladder is not full. Determine the cause of the bleeding. If the uterus is atonic, we also need to get the uterus to contract as quickly as possible. So as long as the uterus is not contracting, the patient will bleed. So we can still try and massage the uterus, or we should still try and massage the uterus to get the clots and etc. out, and to get to stimulate the uterus to contract. And this can be very painful. But if we have already give oxytocin and symptometrin and the same things that we have given for the mother without this cesarean section, and the mother is still bleeding, the only way that we might be able to control the bleeding is to massage the uterus. And then the patient will have to go back to theatre for a relook laparotomy, because maybe it's a blood vessel that's bleeding, or the placental wound that's bleeding. And that brings us to the end of this lesson with postpartum hemorrhage and the management of the 3rd stage of labor. I hope you have learned something, and you need to complete the quiz before you can continue to lesson 4, your final lesson.